Diabetes, right, uh, is often referred to be a silent epidemic. So, what is your thought on diabetes?
Nobody wants to go to a doctor. Like I would go to a restaurant, I would go to for a picnic, but we go to a doctor. Obviously, we are in need of something, and we have some symptoms, or we have some pain. We are in pain, or we have something which you can feel. Or unfortunately, in diabetes, you have a spectrum. So there are people who are grossly symptomatic, and you have people who are totally asymptomatic of disease of the rich, disease of the older people, and those with a very strong families. Again, sitting is the new smoking, including my own job, I would say. Our intake of carbohydrates, and then the social stigma that you're diagnosed with diabetes, the generic advice that would go across is, please cut down your rice. Basically, you're changing from cash to UPI to NEFT or whatever you call it. So our knowledge of food labeling is very bad. In fact, I would say in a family, a person with diabetes has a longer lifespan. If there is 101 million who are diabetics, there are 134 million who are pre-diabetic.
Oh.
So that number is bigger than...
What is the difference between high sugar, pre-diabetes and diabetes?
5.7 to 6.4 is pre-diabetes. Again, you'll be totally asymptomatic. That's the biggest problem there. The textbook knowledge of increased thirst, increased urination, increased overeating, and poor wound healing.
Right.
Again, wound healing is considered like a gold standard. If my wound heals, it's understood that my sugars are well controlled.
Right.
If my wound doesn't heal, it means my sugars are not under control. But healing itself is a very complex process. In fact, the other thing is losing weight. People lose weight, but there are two types of weight loss. Healthy weight loss and unhealthy weight loss.
The first organ that will get affected is the kidney when it comes to diabetes.
So that is why we when we divide, we talk about complications, we talk about microvascular and macrovascular.
Okay.
Probably somebody appearing for an exam, you should pray they don't get diabetes, because head to toe you can be screwed anyway. Your viva. So seasonal fruit, I'm saying mango season, I would in fact drive my people saying, get your A1C below 7 before the mango season. Enjoy your mangoes in the evening. Maybe a half mango. You balance
That is still doable.
Most of my patients do it.
Wow, that could be a breaker, literally. So when you say type 2, carbs is the main culprit there, right? So what is it that they should actually do on a day-to-day basis? Like something very simple, very easy.
Correct. First thing is, please stick on to your staple food, because it is sustainable. Once you have a protein, what happens is it fills your stomach, the appetite comes down, and also it has the carbs when you eat. The sudden spike won't happen. The protein kind of negates the sudden spike. There's nothing sugar-free except water. That is something we need to understand. So we go with sugar-free biscuits. That is basically no added sugar. Biscuit means it's maida, sugar and palm oil.
Okay.
Standard. So you don't have to go give oats biscuit, this added, this friendly.
The no sugar biscuit also has sugar.
In a different form. It's carbohydrate. Carbohydrate is a generic term for everything.
Without moving.
Right.
Is there a possibility that somebody can actually do something to have it in control?
So post-meal exercise of 15 minutes with each meal would help. But again, it's very difficult to implement.
Hi, Dr. Praveen. Thank you so much for taking the time today and coming for an interview with us in Go Mad, Go Make a Difference. We truly believe that you definitely make a difference in the society. Being a renowned diabetologist in the city, it's an honor to host you here today with us.
Thank you once again for hosting me, and it's my pleasure to join your wonderful podcast of Go Mad. I hope my session would be useful for all your followers and the people following your page.
Absolutely, yes. So directly jumping on to your personal front first, right? So did you always want to become a doctor?
Probably, I think everybody has different passion over their childhood, right? We start off initially with some ambition, then things kind of change. I think probably the defining point would be the 10th, I think. I had some sort of interest in general with science, but I definitely didn't want to do engineering. So it was more of a ruling out of things. But medicine was one of things which I definitely thought would pursue. If not medicine, I thought of even dental, the other way around. So I definitely didn't want to do the other one. So if nothing would have worked, probably I would have gone into a pure science and research and something like that.
Okay, so science interested you at this time.
But yeah, that's also part of science, but I wanted the other part of the science.
Okay. All right. So, having said that, you've done your fellowship in CMC, one of the prestigious colleges, right? You name it, you know that, it is a stamp that you are of that level of, what do you say, expertise when it comes to any post-graduation or anything, right? So, how was your experience when you did your fellowship in CMC?
So, as you rightly mentioned, it's a dream college for everyone. And again, getting into a super specialty department again is a big challenge. The cracking was also, the entrance was itself was a tough thing. There was an interview. I probably didn't expect, I'd applied for this and probably in emergency medicine, but I'd scored well in this. As you rightly told, obviously once I was in the department, the first 3 months, I mean, even for me to get adapted itself was a big thing. It was not easy. I definitely thought I would not complete it. That's for sure, because it was hectic. And obviously, I thought somehow I hang in there.
Okay.
But whatever I am today, whatever teachings, it's all I'll owe it to my teachers there. If not for them, a little bit for the practice as well as the knowledge and whatever, it's all because of their guidance.
That's amazing. So could you please let us know about your experience when you were doing your thesis? I think you bagged the first prize, if I'm not wrong, from the University of Queensland as well, right?
That was actually it was a 3-minute thesis presentation.
Okay.
And my boss was the head of research that time, and obviously I was fortunate again to be put into a research where I really didn't know head or tail of it, and it was not like you do a thesis for the name's sake. First of all, getting an opportunity was a big thing. Only few centers in the country do this research, the CLAMP studies, CMC being one of them. So I had an opportunity to be part of it. A lot of hard work was there, and I think the first opening was the annual research day, and I was able to bag a third prize there. And that opened up into the national conferences. Boss believed in me more than what I could believe. He called me back once I was in Bangalore. He said, "Praveen, you come back and present." I never expected that gesture from him. The whole 2 years of story, to put it in 3 minutes, was not a joke. And you had the best of people there, and it went on. I think I got the first prize. But doing it in 3 minutes, I can tell stories, but doing it in 3 minutes was not easy.
That's amazing to hear, actually. Diabetes, right, is often referred to be a silent epidemic. So, what is your thought on diabetes in the current generation, and what are the health issues that are accompanied with that?
Absolutely, I think you used the right term, silent epidemic. We all had a very good pandemic, I think 3 to 4 years back, COVID. And why did we all know is obviously you were grossly symptomatic. You know that people had cough, fever, you had those symptoms, you had the warning signs. So these are the infective diseases, what you call as the communicable diseases. At the other spectrum, you have the non-communicable diseases. You have the diabetes. We talk about obesity, talk about cardiovascular disease that is related to your heart. But again, diabetes plays a very important role in all these other NCDs also. Why am I telling it as a silent epidemic is nobody wants to go to a doctor. Like I would go to a restaurant, I would go to for a picnic, but we go to a doctor, obviously we are in need of something and we have some symptoms, or we have some pain, we are in pain, or we have some something which you can feel, or unfortunately in diabetes you have a spectrum. So there are people who are grossly symptomatic and you have people who are totally asymptomatic. It is randomly picked up for some other investigations. For example, even during the COVID, there are a lot of people who are newly detected with diabetes. In fact, if you look at the mortality, the people who succumbed to COVID and those who had the infection but the mortality was lesser, if you again divide diabetics and non-diabetics, people with diabetes people with poorly controlled diabetes. I would not say everybody who had diabetes had some complications. They were detected to have COVID. When they did their HbA1c, it was 10%, 11%. What happens in COVID also, Second week, when they give during the inflammatory phase, then they give the steroids. So obviously steroids can increase your glucose levels. It was like adding fuel to fire. So one side managing your infection and again uncontrolled diabetes is a very deadly combination. Second thing is the spectrum. I said the other general myth is people assume diabetes is more of disease of the rich, disease of the older people, and those with a very strong family history.
Right.
So definitely genes play a very important role. Genetics, especially our ethnic race, Asian Indians itself is a high risk population. But the problem is, apart from just the family history, both parents are diabetic or a single parent is diabetic, you probably have, I would say, you have 10 or 20 marks you're ahead at baseline. But the other factors, apart from the genetics, when it comes to your obesity, mainly your waist circumference. Again, when you talk about obesity in our population, our waist circumference plays a very important role. And our BMI cutoffs are much stricter. I mean, about 25 you are considered to be obese,
Right. Yeah.
not 30 like the global population. Then again, sitting is the new smoking, including my own job, I would say. And last but not the least is our intake of carbohydrates. Again, more in particular, refined carbohydrates. And as I briefly mentioned last time, we talk about, when you talk about moment somebody says, and then the social stigma that you're diagnosed with diabetes, the generic advice that would go across is, please cut down your rice.
Right.
Just switch over to, if they're from the Mandya Mysore region, they'll say switch over to ragi mudde.
Right.
Probably from North Karnataka, they would say jodad roti.
Yes.
And probably the Bangalore trend is to switch over to millets. Basically, you're changing from cash to UPI to NEFT or whatever you call. So the carb, across the grains, every grain is a carb there, every cereal is a carbohydrate there. But to summarize in short, mainly because of the asymptomatic nature. So early screening is very important. Don't go with the myths of saying that it's above 40 kind of a story. You need to understand Asian Indians, it's 10 years earlier. Your overall intake of refined carbs has gone up 2 to 3 folds. Our knowledge of food labeling is very bad. So this add on to your physical activity and the family history and the genetics puts you at a higher risk. But picking up early would definitely help you in pushing up things or whatever you call, even if you're thinking of, not the reversal is not the correct term, but if you want, even if you have diabetes, in fact, I would say in a family, a person with diabetes has a longer lifespan compared to a non-diabetic. We recently published a paper leaving up to 90 healthy in type 2, I think, the recent publications.
Okay.
So these are all SIRS patients, and there are people who have, so they are the live example. You didn't have the fancy drugs or the fancy insulin. They're very conventional, but what they had the basic discipline in their life. And if you have the discipline, definitely you can, even if you have diabetes, you can live healthy.
Oh, that is news to me as well. So when you say diabetes, it is the sugar level in your blood, isn't it? Am I right?
Yes. So a lot of people ask us the same question. I have a urine sugar or a blood sugar. So we call any elevated blood glucose level dysglycemia. First you should understand what is normal blood glucose level. When I say normal, a fasting blood glucose. Again, when I say fasting, it's 8 to 12 hours of window. And when you check, it's not your glucometer, it's your venous blood, what you do it in our lab.
Oh.
So fasting, because this is a capillary, the glucometer measures your capillary blood.
Okay.
Not that it is wrong. Again, when for diagnosis, you better rely on a venous blood.
So, I mean, the pricking, everyday pricking or weekly once pricking at home is
No, it's good.
Okay.
But when you diagnose somebody, so you cannot go every day and you not go give a sample at morning 8 o'clock, then again post meal 2 hours, post lunch 2 hours. So definitely glucometer or the CGM devices are part of your, for your monitoring, definitely you require it. I'm talking about diagnosis.
Okay.
When you say that you are labeling somebody as normal pre-diabetes or diabetes, you need to give the sample, the venous blood sample, and a fasting blood glucose less than 100 milligram per deciliter. A post meal. Again, gold standard is the oral glucose tolerance test. You need to give a 75 gram glucose. Otherwise, you'll say I had dosa in the iconic hotel we have in our area. I had chapati at my home. So there's no standardization. But this is for somebody who's not diagnosed with diabetes. So you give a glucose tolerance test, you collect a 0 hour, 1 hour and 2 hour sample, and then you label them based on the cutoff. Then there's a very important test called as the HbA1c. This is again a very important test because sometimes Now you do a random blood sugar test. Probably you do a pre-lunch you would do, or you may do it after 2 hours. You would say 140, 150, random looks good. But probably you would have missed out the peak sugar values. So that is where your HbA1c test helps you. So HbA1c more than 6.5 is considered to have, I mean, you're considered, you're in the diabetic range. But what I would consider as a window of opportunity is 5.7 to 6.4, what you call as pre-diabetes.
Okay.
And if I just tell one of a very alarming statistic, if a recent INDIAB study, that's our epidemiology, nationwide epidemiology study along with ICMR, if there is 101 million who are diabetics, there are 134 million who are pre-diabetic.
Oh.
So that number is bigger than the...
That is very scary.
So that's going to feed into sooner or later. So whether that 134, I mean, it is going to progress, but at least if you focus and if you can cut down the transition, probably the numbers can at least remain stable. Otherwise, there will be an exponential rise in the numbers in the next 10 to 15 years.
Absolutely. So when you say diabetes, what is the difference between high sugar, pre-diabetes and diabetes?
5.7 to 6.4 is pre-diabetes. Again, you'll be totally asymptomatic. That's the biggest problem there.
Okay.
The other good part is your beta cells, that is your pancreas is so programmed so well. So if there is loss of 10 to 20% of your beta cells, that is the insulin producing cells, the remaining 60-70% compensate.
Okay.
So that's how they compensate, and you won't see the difference in terms of your routine metabolism. Over a period of time, if this compensation keeps failing with whatever the reason, because of the abdominal obesity, excess carbs, you have gained weight, your physical activity has gone down, that's when probably a diagnosis, your beta cell comes down by 40 to 50%. So you're running the show by 50 to 60% itself. That is why, but once you lose that, again to bring them back is not easy. That is one thing. Now there are a lot of people who are between that 5.7 to 6.4, and again whether without screening you would not know. Above 6.5 you're diabetic, agreed. Again, grossly, what you have again, the textbook knowledge of increased thirst, increased urination, increased overeating, and poor wound healing.
Right.
Again, wound healing is considered like a gold standard. If my wound heals, it's understood that my sugars are well controlled. If my wound doesn't heal, it means my sugars are not under control. But healing itself is a very complex process. Diabetes is one of the factors for poor healing, but that doesn't mean that just because your wound heals doesn't mean your sugars are under control. That is where the glucometer, what you mentioned, is very important in terms of monitoring. Then 5.7, 5.6 is your normal, 5.7 to 6.4 is pre-diabetes, more than 6.5 is greater, I mean, even 6.5 is diabetes.
Okay.
But when you see a gross symptoms, it is generally would be above 8 or 9%. That is the challenge there.
Okay.
You would probably an 8%, 7.5, you would be asymptomatic. You would have gone for some other evaluation, this would have been picked up randomly. But if you can pick it up early, it's always better in the longer run.
Okay, is it always that you go for something else and diabetes just comes along, or is it because of diabetes that you end up having something else?
Both the things are absolutely right. So you would have actually gone for a burning urination or a urinary tract infection, recurrent. The doctor would have given a course of antibiotic, would given one more course.
Right.
Still there would be the infection, there will be recurrence of infection. Then you would say, are you diabetic? When he says no, then probably when he checks, you would see a random sugar of 230, 240. Then it's kind of a retrospective evaluation there. Then other way around, again, the family history and that matters. There are people who would have seen their family suffering with one of these similar symptoms. So they would have this little awareness, and thanks to today's Google, I think people would Google and say, my feet is burning, or I have increased, I'm losing. In fact, the other thing is losing weight. People lose weight, but there are two types of weight loss, healthy weight loss and unhealthy weight loss. Generally, when this HbA1c is about 10 or 11, you do see this osmotic symptoms. And that can again cause unhealthy weight loss. Who lose around 4 to 5 kgs, especially people who present to us with 300, 400 sugars, they lose around 4 to 5 kgs. Initially, they think it's because they have restricted their calories, they're walking more.
Right.
Very unlikely.
Okay.
Again, see, weight loss is again more to do with your diet. I mean, than restricting your calories, than your exercise. Probably you may include an extra round in your walking, but that's not going to make a huge difference compared to your
3 to 4
calories.
is quite a big number too.
So obviously, when levels are 400, you will be losing some sugar in the urine. So the renal threshold is 180. So whenever the glucose levels are above 180, you will see the sugar appearing in the urine.
Okay.
There's nothing like blood sugar or urine sugar. It's that when it crosses a certain threshold, it would appear in the urine. Somebody at 6.8, 7%, you would say urine sugar may not be there.
Okay.
So you cannot go with saying that urine sugar is nil, I don't have diabetes. So it's just that renal kidneys threshold is around 180. So above 180, you would see the glucose appearing in the urine.
So the first organ that will get affected is the kidney when it comes to diabetes.
So that is why when we talk about complications, we talk about microvascular and macrovascular.
Okay.
Micro, you say, is the small blood vessels.
Okay.
Macro means big. Then when you say micro, it's basically the small blood vessels in your eye, retina. Retina and kidney are friends. So,
okay.
So kidney is the other organ.
Okay.
The protein leakage we call. And then you have the nerves, neuropathy. This is retinopathy, and this you have your nephropathy.
Okay.
All three are micro.
Okay.
Then you have your macro, the heart, the cardiovascular disease. Then you have the cerebrovascular, your brain and stroke and all that. And peripheral vascular, the blood vessels. You see a lot of foot ulcers. So again, very common in people with smokers, chronic smokers. But again, long-standing diabetes, poorly controlled with your peripheral neuropathy, then you can develop these ulcers, as well as the non-healing ulcers, as well as the food complications. So it affects head to toe. Probably somebody appearing for an exam, they should pray they don't get diabetes, because head to toe you can be screwed anyway in the examination in your viva. So you can, so you pray that you don't get this case, because you can pick up anything and everything and you can relate it to diabetes.
Could you please share about the different types of diabetes that is there right now?
So generally people assume that every type of diabetes is same, but in fact, when you divide diabetes in general, you can broadly divide it into type 1, majorly affecting the children. You have the type 2, what you see, the bread and butter, the garden variety, almost it constitutes around 90% of the total types of diabetes. And you have the gestational diabetes, what you see during pregnancy. But again, if you look into some of the other rarer forms, you have what you call as generally a younger diabetes, less than 30 years. You would also see something called as the maturity onset diabetes, or MOD we call. It's very important to diagnose this, because these are generally labeled as type 1. Okay. And in type 1, insulin is the treatment of choice. So in type 1 diabetes is an autoimmune type of diabetes where your beta cells, the pancreas, the insulin producing beta cells are destroyed by your own immune system.
Okay.
So it's nothing to do with your lifestyle, though there may be a viral infection to trigger, or though we don't have an exact reason for type 1, but it's an autoimmune form of diabetes. In a proven type 1, insulin remains the treatment of choice. And when I say insulin, it's just not one shot. It's ideally 4 shots in a day. That is 3 short-acting insulin before your major meal, 1 long-acting insulin at bedtime. And lifelong they have to be on either this, or you have the insulin pumps in people who can afford. And managing a kid who's having school, stress, their routine activities, managing the social stigma is not a joke. So that's one thing. Then you have type 2. So in type 2, it's a combination of both your beta cells not producing adequate insulin with a background of insulin resistance. So insulin is there, but you're not able to produce, mainly again mediated because of obesity. And that is why some segment of type 2, what you call as an insulin resistant obese type 2, you have some good chance of remission. The reversal is not the correct word. Remission is the correct terminology. So if you lose healthy weight loss, if your duration of diabetes is much lesser, so the beta cell damage is much lesser, and if you can adhere to the discipline of cutting down your carbs and have a disciplined lifestyle, you can be off medicines. But again, you're indisciplined, you'll again get back. So that's the difference between a reversal and remission.
Okay.
So a reversal, in the sense, it should never come back. Remission, you do certain things in a certain subtype of type 2, yes, chances are there. But again, it's not like the ads which are shown that you can have jalebis. It's not about you should not have jalebi or a rasgulla. You can definitely have. And we never say anyone not to have, because general assumption is, if I am diagnosed with diabetes, I should not have sweets. I should not have rice. But you're not. Those are the direct sugars. Again, in moderation. Seasonal fruit, and I'm saying mango season, I would in fact bribe my people saying, get your A1C below 7 before the mango season, enjoy your mangoes in the evening, maybe a half mango. You balance
That is still doable.
Most of my patients do it. And
Wow, that could be a breaker, literally. I mean, a person who is having sugar or diabetes.
they can have mangoes. It's not about, see, there are low GI fruits, but I'm saying with somebody who's managed their sugars very well, these are seasonal fruits.
Right.
Now, me telling them not to have is not making them go not have. So they would still have their juices, and so rather than having an unrealistic expectation, it's important to tell them that you can have, but not when your levels are at 9%, 10%. So you keep things under control. Maybe in a weekly once or twice or alternate. I mean, something in moderation. Balance your carbs in your other meal. That is something you can have. So it's not a strict rule saying I should not have. So that is one thing I was talking about the types of diabetes there, that's type 2 there. Then you have again the pregnancy, that's what you call as gestational diabetes. Again, screening is very important. Generally, people who are pre-diabetic before pregnancy generally progress. That is why early screening is again important. Apart from getting the other routine tests during your pregnancy, get an HbA1c. Okay. What it does is get a fasting blood sugar and get an HbA1c, because general screening happens at 24 to 28 weeks. But it's too late. That is why the guidelines are changing, and there are a lot of studies to show that early screening in gestational diabetes is important, in the sense, if somebody is planning pregnancy, 3 months prior, 6 months prior, please get at least a fasting blood sugar, an HbA1c. If you're in the higher side, the weight is on the higher side, try to lose some kilos before your pregnancy, so that your pregnancy journey becomes easier. If your A1C is around 5.56% before your pregnancy, you can easily progress during pregnancy. So at least if you know that you are at 6%, from the first initial days, you start having a discipline in your diet, what you call as the medical nutrition therapy, MNT we call. And a proper MNT will at least delay your progression. Even if you develop mild gestational diabetes, you can be managed probably in the last trimester. But probably if you don't pick it up, at 28, 24 weeks, the damage is already done. It can affect the babies in terms of even the delivery outcomes, and even for mom to progress into type 2 is also almost 10-fold higher in people who have gestational diabetes. And weight again plays a very important role. Post-gestational, the weight gain. Again, there's a lot of pressure, right? Again, the social pressure during pregnancy. You need to eat more. The baby should be fed well and all that. So, but again, there's a big challenge in balancing your carbs there. So again, early screening helps in gestational diabetes.
So when you say type 2, carbs is the main culprit there, right? So what is it that they should actually do on a day-to-day basis? Like something very simple, very easy.
Correct.
Which does not require much of...
See, I think we take a lot of stress over diet, about what to eat, what not to eat, and we kind of get into a frustration mode saying that if this should not be eaten, that should not be eaten, then what should I eat? In general, to make it very easy for the audience, in general, our carbohydrate consumption, and when I say carbohydrate, includes all your cereals. It could be rice, it could be ragi, it could be rava, it could be your millets. Everything has carbs in it. The general consumption is almost 70%. 70 to 80%, I would say. And what is lacking is the protein and the healthy fat. And again, when I talk about protein in general, we assume that, vegetarians generally their protein intake is bad. Non-vegetarians, it's pretty good. Partially true. First thing is, please stick on to your staple food, because it is sustainable. The thumb rule of, if you say rice, probable example would be, if the option is available, switch over to rice which are less polished. So when rice is less polished, your bran is retained. So obviously the fiber content is there. And obviously when you eat even a little amount, you feel full. And when I say the less polished rice, it means the brown rice. Just because the rice is brown, that's not brown rice. You get the one which is intact bran. And it takes longer time. Probably while cooking, it may take a couple of more whistles more. And when I say there's other there's red rice, there is rajmudi rice. But again, portion is important. Now, just because I'm eating brown rice, you cannot eat more. That's a different story. The other option is to fill in the protein first. So morning, the staple breakfast for many would be idli, dosa, or upma, poha. So simple example I tell for vegetarians, you would probably go with 3 idlis in the morning or 4 idlis. I'm pretty sure with idli comes the chutney pudi or the chutney. At 11:30 again we'll feel hungry.
Yeah, actually, that's
You will feel like I want to eat something, probably a biscuit there, a coffee or a tea. Problem is only plain idli with chutney is like having a simple carb. You have only carbs there. I know the ratio of dal and rice in idli goes in, but that ratio also is more in favor of the carbs. Now the same idli if you can include with a cup of sundal, the green gram, Bengal gram, or in a non-vegetarian a scrambled egg or an egg white, the story changes. Probably you would hold on with 2 idlis, 3 idlis, would not exceed for the fourth one. And when you include with an egg white or a sundal, the chana, probably you will hold on till 1 o'clock or 1:30. You will not feel hungry. So when you include a protein in the morning, it also has an effect on your second meal. And the craving comes down.
Okay.
And probably the other way of, this is one example. The other thing is sambar. When I mean sambar, it's not the water sambar. You need to have again more dal in it. And if nothing is there, have cucumber, carrot salad or something, and then include your the idli portion. Now you like poha, okay, poha is fine. So everybody can eat poha. So you don't have to change the breakfast menu for the family. You just need to do an extra protein in your. You need to include in your cuisine. The issue now, I tell Sundal, majority even before tasting, or I would say, I feel it gaseous. I feel a lot of flatulence.
Right.
There is this preconceived notion. That's the other challenge. The same thing comes from the temple. We are very happy to eat without complaining. But the point is, the third thing is doing it. Now, there are a lot of people who are elderly. They depend on somebody. Again, doing a sundal in the morning. Some are okay with it. Some are pretty happy about it. Some don't. Now, I say, no, apart from that, I say paneer. Morning, I can't eat paneer.
Yes.
Mushroom, no, I don't eat. No, in a vegetarian, that's where the options comes down. But I'm saying still, you can work around it. Now, this is something I told for your breakfast, your lunch. You want to stick on to a single cereal. A lot of people again would have 2 chapatis and then go to rice. They'll have ragi ball and then rice. You stick on to single cereal, this or that. But before you start that, first finish your green salad. First have some vegetable palya there. You finish off all that. Or you again want to include a protein there. You're not eaten, you had sundal in the morning, you can have an egg omelette or something in the afternoon. Then come to your grain at the end. It's basically, if you see the Western diet there, the herb rice or the is given at the end. You kind of finish off all your other broccoli, your vegetables, and then basically you need to have that. You need to fill up your stomach with other things, and then come. Even if you have a buttermilk, that's fine. But the point is, we assume that I drink buttermilk, I will not eat.
Yeah.
But once you have a protein, what happens is kind of it fills your stomach, so your appetite comes down, and also it has the carbs when you eat. The sudden spike won't happen. The protein kind of negates the sudden spike. So even a high GI food, if you include a protein, it kind of becomes a medium GI.
Okay.
So rather than confusing too much of changing the cereal, and we have some studies, even most of the millets which are available in the market are polished millets.
Oh.
And polished millets are worse than rice.
Who is it?
See, rice, the advantage is you get a satiety. But see, if you're eating white rice, you should have more of pappu, dal, so that.
Yeah.
But the problem is you will not finish at one serving. You will have kind of 2 or 3 servings.
Right.
Now, you make a brown rice pulao, probably you would stop at 1 serving. So it's all about what to eat and how to eat things. That is what is important. Proportion matters, quantity matters. And other less discussed thing in our cuisine is the evening snacks. We are very meticulous about the 3 major meals. Evening, there would be 3 biscuits coming in with coffee or tea, some mixture, muruku or savories or something. We underestimate the calorie impact of these things. There's nothing sugar-free except water. That is something we need to understand. So we go with sugar-free biscuits. That is basically no added sugar. Biscuit means it's maida, sugar and palm oil.
Okay.
Standard. So you don't have to go give oats biscuit,
yes.
this added, this friendly biscuit.
No.
Please have some time, open up the food labeling behind. Please read about it. It's a little difficult to decode. But the point is, when you read about it, oats biscuit is not made of oats. Oats is just kept like a topping at the end. It's still, without maida, binding won't happen in any bakery product. So the problem is, you save around 4 grams, 5 grams of sugar by not adding in your sugar. You kind of take it in a different way.
So the no sugar biscuit also has sugar?
In a different form. It's carbohydrate. Carbohydrate is a generic term for everything. In fact, it is having a refined carbohydrate.
Which is even worse.
And you don't stop it at 1 because it is addictive.
Yes,
so you will have 1 more biscuit. You will have 1 more biscuit, probably 2 to 3 biscuits. That's almost more, it's actually worse than what you would have added a 1/4 of. I'm not telling them to add, but our assumption is we are saving here, but you're kind of taking it in a different route. That's why I mentioned at the first. In our language, it's the reducing carbs is always about switching from one mode of payment to other mode rather than restricting it. The other thing is the evening so-called snacks is again not mandatory. If you include a protein with your lunch, probably will not feel hungry. You could switch over to a fruit, but again, the assumption is fruit is sweet,
Yes.
whereas the mixture is kara. So,
No, but generally we all think, right, fruit also has
so
sugar.
when you talk about fruit, you can again switch over fruits into low GI, medium GI, and high GI. You can have all three. Again, depends on each one's condition there. But I regularly use fruits like apple, guava, kiwi, mosambi, orange, pomegranate, papaya. All these are low GI fruits. But when I say low GI, there are two things when you talk about fruit. Amount of ripening matters. Because more the ripening, more is the fructose content.
Okay.
But again, there are fruits you can eat, like guava, you can eat little bit medium ripened, not fully ripened. But there are fruits which it has to be ripened, otherwise the taste won't be
Banana.
there. Bananas. So you can have the low GI fruits somewhere around 80% ripened, but quantity matters. Just because I say a fruit is good, you cannot have a fruit salad there. You just stick on because you cannot quantify. That's the whole challenge. Probably one or two fruits, a small bowl. Along with that, a coffee, tea. But again, people have issues having a combo of fruits
Fruit and
with coffee. Other thing you generally see during holidays is when you go for this buffets, right? Morning people think having a fruit is like a very healthy option. So, and that's not considered as carbs at all. So you finish your fruits and then they will have their breakfast. So it's a double breakfast.
So you're saying that one fruit salad bowl by itself is a breakfast?
Some calories. You need to count the calories there. Breakfast would have around 200 to 250 kilocalories. I'm not talking a buffet would be around 400, 450. But you would have 100 there, another 100. And you assume that I'm average. Fruits have eaten is a very a safe option. The other common trending thing is to have porridges in the morning. I don't want to mention the brands or anything, but it's a very common thing to have forget about the brands. The homemade mixed the different ganjis. You have homemade, I've used this millet, I've used this protein powders, I've done all that sattu mavu or whatever you want to include it. So instead of coffee, you kind of have this porridges. A coffee would be with milk, would be around 45-50 kilocalories. Probably I'm saying I'm 200 ml with milk. Now a porridge again with the same quantity, 200 ml with what all you make, would be around 100 to 150. It's more calorie rich. So you kind of have this. What happens is you delay your breakfast because it's neither a snack, neither a breakfast. You assume that you're going for a walk. You assume that we overemphasize this exercise of walking a little bit too much because you kind of walk for 30 minutes, hardly burn around 50 calories or something. But you kind of even a bit of sweating, you assume that you have burnt a lot of calories.
Right.
You come back and tend to eat more. Probably post walking, you have the legendary eateries near to every park. So people finish a semi breakfast there, and then they come back home and have a second breakfast. So basically, you're loading in more than expected. And in the walking is just like a accessory thing which you have done. In fact, if you don't walk, if you do some good resistance training exercises at home, if you restrict your calories, 50% of problem is solved. But the problem is the pseudo walking happens. Post that there is a couple of sessions of some people have couple of coffees there.
Right, yeah.
Then that is where all the hot topics get discussed, the daily. Then comes, ultimately your breakfast is delayed, your medications are delayed, your lunch is delayed. Everything is a vicious cycle. See, my general advice for most of them would be with nuts. When I say nuts, these are healthy fat. Again, there's a lot of myths, right? So you say nuts, they say I eat cashews, I'll gain weight.
Yeah.
So you have cashews, you can eat cashews. Raw cashews, I'm not talking about the roasted cashews, raw cashews, walnuts, almonds, you have the boiled peanuts also. So again, between breakfast and lunch, you're hungry, probably you can have these nuts. You have a handful and you kind of feel full. And the healthy fat will improve your good cholesterol. Now when you roast it and kind of put salt, that's when the problem is. Now again, eating right thing at right time. Now I spoke about bread, right? You can have bread with your paneer or omelette as your breakfast. Now you take this 2 bread and have along with your tea in the evening. That's a snack. That's not a snack. It's one more meal there. So your pre-dinner levels will definitely go up. Next day your fasting level goes up. But person's assumption would be, I've had only 2 chapatis for dinner. How did my levels go high? You forgot this 5 o'clock or the puffed rice. The puffed rice is considered like a very big, just because an item is light, is assumed it's a lighter snack, but that doesn't translate into your blood glucose levels.
Okay.
And you include your charts there, include the makanas.
Yes.
In my first consultation, generally when I do, I give those 5-10 minutes for the diet part, because that's more important. I know diagnosis, medications is the other part. But unless you don't fix your lifestyle, diet and other things, it's not going to work. As simple as that. Second thing is the job they do. Now somebody I'm dealing is somebody who has a night shift. Your entire circadian rhythm is disturbed. Now there you can, and I'm dealing somebody who's in marketing job. He generally needs to travel throughout the day. You cannot expect 11 o'clock you eat sundal, at 2 o'clock you whatever he gets. Again, the problem is the healthier options are also much lesser. Now I probably make a sundal shop, probably my business won't run.
Actually,
The economics is the other challenge.
Right.
And the ones which are healthier are slightly expensive. Let's say pomegranate you take, probably you have a kiwi fruit. And the ones which are junk are more cheaper. So there's a kind of a vicious cycle there. So even the policies which have to be done have to focus. Now when you talk about free rice, we talk about free rice plus dal. Or like in the midday school program they had about, I think, egg, including egg. Egg, if not egg, the chana, the green grams or something. So that balance is something. So science should go along with the policy makers. I mean, the science should translate when you make these policies. And at least for the youngsters and the college going, school going children, the knowledge about food labeling is very important. Hardly takes, I think, a little bit. Today we have so much information available. You need to inculcate, because they assume the access for them, a problem begins at 25, 30. The problem starts actually at 10 years. I mean, you start eating all this, that's when the process begins there. So that is when, and that's more easy to correct at that stage, rather than once they're kind of used to it. And last but not the least is our physical activity.
Yes.
Sports. I think sports is one thing, apart from today, it's an academic driven world, but in general, I think you cannot tell a 10-year-old to say go for a walk or something. Whatever is interested, I think, apart from the all the e-games and the virtual world, stepping out is important. And some sort of sport will definitely help both in academics as well as to have an overall healthy lifestyle.
When you talk about lifestyle, right? So these days, like you said, majority of them long working hours. So they start at 9 in the morning and maybe till the night 9 o'clock, they are just stuck to one place.
Right.
So that causes obesity also, right? So that also will have an impact on your sugar levels in your body. So how can you actually, you are at one place, you have no choice, you cannot move. So without moving, is there a possibility that somebody can actually do something to have it in control?
So you need to, again, few things. I think you're absolutely, I think there are some people really don't want to, even though they wish to have a time for themselves, probably they would not be able to dedicate it. One small balance we need to crack is, if you're not able to do your routine walk, what I told about in the parks or dedicated time for physical activity, even a post-meal exercise of 15 minutes with each meal would help. But again, it's very difficult to implement. Even if you're working from home, I would suggest 30 minutes, please have a break. Not that you break in the sense you be off your meeting. It's not that 30 minutes you'll be focusing in your system. You will have some breathing space. Probably you need to probably you may walk within the room 10-15 minutes. Doesn't matter. Though it is little not the conventional way of doing it. Definitely they can include this thing. And apart from walking, you do have the strength training exercises and other things. But the problem is it's not easy. One side you would have work, stress, and other way to balance this. I think both don't go hand in hand.
Right.
But somewhere I think you need to draw a line and say that these 2 hours is for me. 7 hours is for the company. I think 2 hours is for me, or 1 hour is for me. And somewhere you need to incorporate. I think once everybody starts putting their foot down and saying that this is my priority, I think it is possible. But there are jobs becomes extremely difficult, and that is where it's not about just I do it on weekends and I forget on the weekdays. That's not going to help us, because you need to restrict your calories. For the kind of desk job I'm doing, this is the amount of carbs I need to have. This is what. So that is the other way of doing it. So if you're not able to do it, restrict the calories, avoid the unnecessary. See, again, there is an issue of stress eating. We look for excuses, but this is somewhere we need to, that is where your other form of sports, meditation, yoga kind of helps you. That is why to have a holistic approach is extremely important in such cases.
So when you say yoga also plays a major role in controlling?
I would say yoga along with other exercises definitely help. I think, but again, using again when I get why I'm talking not in a negative way, but there are people who would say like I'm doing this many hours of yoga, forget about the calories part. I'm doing yoga, so I'm eating all this.
Okay.
So my point is, just because you're doing yoga, it doesn't give you a license to go overboard.
Right, that is right.
That's part of your exercise. You have I think pranayama definitely helps with this bringing down your stress levels, having a good focus, having the discipline. All your other asanas also one form of strength training exercises. But apart from that, the basics of discipline in your dietary restriction of calories is something very important.
The roots have to be
followed.
So coming to signs and symptoms, right? Is there a way that general public will be able to know that maybe I should go for a test apart from the regular blood checkups that they do?
It's a very good question. I think very simple markers, I would say. We have a score called as Indian Diabetes Risk Score, IDRS. So this again incorporates not your blood tests, it includes your family history. Both parents are diabetes, probably you get 20 marks, one parent is 10 marks, as I mentioned earlier. Then you have your waist circumference.
Okay.
Waist. So in general, in males, ideally it should be less than 90 centimeters, that is 32 inches. And females less than 80 centimeters.
99%.
So there you get again 10 marks, 20 marks and 30 marks. So above 100, 110. So you have grades there. Then you have your activity, what you told about your the moderate physical activity. Again, I'm working from home, morning to night, sitting at one place, straight away 30 points. Then you have moderate 20. You have intense exercise around 10 points. So again, when you tabulate all this, probably you get this, any score more than 50, you get into high risk. So you need to be screened more often. Somebody is at a lower risk, less 20, 30, very unlikely, as you rightly mentioned, by default, majority will fall into that 40, 50.
Yes.
So getting an annual screening should not be a problem. I think today, most of the, apart from the work, the stressful job is you do have people, whichever, whether it's not only about the IT companies, I'm saying in general about any job, getting an annual screening would help. And apart from these, IDRS score, in females, if they have irregular cycles, which we know that there's a connection of PCOD with diabetes, mainly because of insulin resistance. Then you have this markers, signs of insulin resistance, what you call as acanthosis nigricans, the darkening of your skin at the nape of your neck.
Right.
So you see a lot of people, youngsters, childhood obesity, would see a dark skin. They would actually visit a dermatologist for a cosmetic reason.
Right, yeah.
Yeah, because the skin is on the. So that's again a sign of severe insulin resistance or hyperinsulinemia. That's again because of obesity. So that's again a precursor.
Okay.
So if somebody at 12 years, 14 years is having an acanthosis, you have a very good chance of progressing unless you don't lose weight.
Okay.
And the last but not the least is the bigger challenge is the social stigma of moment if anybody meets each other, the first talk is about the weight.
Right.
So even if somebody really genuinely loses weight and cuts his or her carbs and kind of comes down, and there are a few newer diabetic medications which helps in weight loss. So we'll be very happy that this person can achieve remission, or we can bring down his insulin or bring down his medications. Post their 3 to 4 kgs of weight loss, mainly because of the social stigma, they would come back. Everybody who's looking at me are telling I'm losing weight, I'm not looking healthy. So being obese is considered healthy. So again, you try to pull them back into a normal routine. So, the family pressure kind of pulls them back.
So, what is pediatric diabetology? I mean, what is the age when the children start getting diabetes, which is very alarming in the current generation, isn't it?
So, there's nothing like an age cutoff that at what age children would get, because the spectrum of diabetes you would generally see in a pediatric age group is the maximum is the type 1 diabetes. Unfortunately, type 1 diabetes generally has a very rapid course. You would generally, there is a complication, a very common complication in type 1, what you call as a diabetic ketoacidosis. So weight loss, failure to the typical growth won't happen. They would come with some sort of an infection and with extremely high blood glucose levels. Because again, picking this up even by a pediatrician at an early stage is extremely, in the sense, repeated infection, then he would probably think of, or losing weight, is not attaining his growth, his milestones, then probably they may say, we'll get a blood test done. In a pediatric age group, we don't do those blood tests as frequently, and that is not required. And again, most of the time, the diagnosis in a type 1 generally happens in a hospital setting. I think they would go with a very high blood glucose level, 400, 500 requiring admission, and what I mentioned, diabetic ketoacidosis. It's a life-threatening complication if not treated. Then you have the pediatric, in the sense the early type 2, that is mainly because of childhood obesity. Mainly you would see BMI even with an age of 12, 14, mainly because of the prevalence. Today we have, even with 12 years, 13 years, type 2. I'm not talking about type 1. Now you talk about 8 years type 1, 7 years type 1, nobody would be surprised there. But if you have somebody coming to you 12 years, 14 years on a pill, then that's actually again mediated because of obesity. And so in a way, it is good that they're not on insulin. But again, to say that there's an increasing prevalence of these numbers, where below 20 years you're seeing type 2, not the type 1, which is a common thing. And I've had a kind of I would not say an interesting case, but somebody who was diagnosed as type 1, but turned out to be type 2. Again, obesity was the reason, and we had the genetic diagnosis, a maturity onset diabetes, in somebody who was labeled as type 1, to be switched over to medications. Getting a correct diagnosis, what you call as precision diabetes, is also a challenge in that age group. So in fact, working up a case, an young onset diabetes, less than 30 years, itself is a challenge. And unfortunately, like before, type 1 would be lean, type 2 would be obese. You cannot go with these BMI cutoff diagnosis. You have people who are type 1 with obesity, what you call as double diabetes, and you have people who are type 2 who are lean, lesser BMI, probably in a severe insulin deficient subtype. So the spectrum is wide, and you cannot go with one size fits all.
But is it true, like if you are type 2 and if you have low sugar, if you eat sugar, it will be normal?
Any diabetes for that matter, type 1 or type 2, you can get low sugar. Why does low sugar happen is, either in a type 1, your dosage of insulin is more, or your intake is less, or you're having too much of simple carbs where you have a lot of fluctuations. You are checking at one time point. You would maybe, the levels were higher at 1 hour, and at second hour it has come down. And probably you delayed your lunch time, you would have had a low sugar. So when you say low sugar, less than 70 milligram per deciliter is considered as hypoglycemia or low sugar. Again, there are people who will be at 200 plus. They would get low sugar symptoms at 150. So even without checking their sugar levels, they would start munching, which is not a right thing. And you again take any direct sugars, your blood glucose levels will go up. But below 70 is an emergency, and it has to be treated with direct sugars. In the sense like glucose or your sugar, teaspoon, what you have sugar at home. Again, people tend to have biscuits and chocolates, which are again mixed with your fat, and you're not supposed to take them. If your blood glucose levels is below 70, or what you call as the first alert value, you need to either have 3 teaspoons of sugar or the glucose, not the complex carbs. So that is one time you have a license to have a 200 ml of fruit juice or something. But you need to check before you diagnose. You cannot say, with my experience, 20 years, I am feeling tired. You can also have hypoglycemic unawareness. The blood glucose will be extremely low and people would not know that it is low. That is one spectrum. Then at the other end, the levels from 200 would have come to 100. And because it has always been above 200 for the person, he gets those low sugar symptoms at 100. So the first thing is, that is where the glucometer helps. And you need to check. And you cannot run to a lab at that time, or you cannot eat something. And if you do that, it's important you document the low sugar value.
Is it true that people who are wanting to eat a sweet after a meal, they might have sugar or diabetes?
Sweet cravings can be there for a lot of reasons, but it's not the only craving that you need to have. Some people are used as a pattern. They've been doing this from their childhood. They would like to have something sweet post their meal, but that's not the only reason. And there are people who kind of don't take any of these sweets, so they have this Generally in diabetics, because they're not supposed to eat all this, they get this. That is what happens when you tell somebody not to do it. Obviously, they have a craving to do it, so they tend to eat. But there's nothing to do with that.
Okay.
But again, somebody with even very high blood glucose levels, 300, uncontrolled diabetes, tend to eat more because whatever they're eating is going down the urine.
Right. Okay.
They're basically having some osmotic symptoms. Their blood cells are not getting the glucose which is supposed to get. And because of that, they're eating more. What we are assuming is, again, he's having low blood glucose levels.
Okay.
Again, they wouldn't have checked the levels.
Okay.
That is the biggest challenge there. So apart from their routine blood tests and what they do, it's important they have a glucometer at home, at least to monitor weekly once or twice, depending on their blood glucose levels. At least, and they keep a track.
Right.
So it becomes easy for the treating physician to kind of adjust the dosage. And
Same thing goes with sweating a lot also.
correct. So in ladies post-menopause, you get a lot of flushes,
Right.
sweating. So they say sweating is associated with low sugar.
Yes.
And again, they'll be popping off some sweets or sugar. So that's
Right.
again a very wrong notion. Not supposed to. Even they've gone probably 3 rounds of walking. Probably in a humid place like Chennai, or Mangalore, you would kind of sweat. Even if you're sitting, that doesn't mean that you have low sugar.
Right.
But in Bangalore, probably you may do uphill. Probably in October, you would not sweat at all. So sweating is also not a metric to judge whether you have a high or a low sugar.
Okay. What is your take on this sugar-free tablets?
Okay, so basically, sugar-free tablets are artificial sweeteners. As I mentioned, there's nothing sugar-free except water. But again, among the artificial sweeteners, you have certain class which is relatively safe, and certain class which are not supposed to be safe. So you have what you call as sucralose, which is one form of artificial sweetener. Then you have stevia, again a plant-based. So again, these are relatively safe when compared to some of the other older artificial sweeteners. But again, in moderation, 1 or 2 pills you can have it. Probably these have lesser calories compared to your conventional sugar. Since you spoke about this, a lot of people replace these artificial sweeteners with jaggery or honey. In fact, I've seen some of the fruit juice shops. So I observe these things not to sit and argue with them, just to understand what the mindset is. We prepare juice with jaggery for diabetics. So when you send that kind of an information, it says that probably people with diabetes can have jaggery. Agreed that jaggery, as compared to your conventional sugar, is rich in iron, has some advantage, but doesn't, in terms of calories, there's not much of difference there.
Okay.
So you take a jaggery, again it's the same cash to UPI story. That is apply here also. So either you want to use these artificial sweeteners, that is sucralose or stevia is one option, or completely be off sugar. But that's another option. There are people who are comfortable. That has to be individualized based on person's comfort. But again, not having sugar-free tablets and having 2 biscuits, you're almost gone.
You're gone there. Yeah.
That's the general, or rusk as a bakery product. I forgot about rusk and some of the.
That is a favorite snack with the tea.
Snack with the tea. Again, wheat rusk, ragi rusk,
Yeah.
millet rusk. So please have some couple of time. I know people think before eating this person advocates about food labeling. Though it's what I mean to say is you need to have that awareness. Either do it thinking that I know that I'm eating this, go full on. There's nothing wrong in that, and have discipline later on. Rather than being this, I'm eating sugar-free kind of relaxation and then not following is not a right thing.
Okay. So when it comes to family, right? If one person is diagnosed with diabetes, how is it that the other people will be able to manage that? Psychologically also it plays a major role, right?
I think family support is extremely important, and family and social support is extremely important in diabetes. It's all about how we take it. It's not easy, especially in somebody. We face this in a everyday basis. Breaking this thing, somebody is newly detected, is not easy. Especially, for us, the bigger challenge is type 1. It's not easy to handle the parents or the child, and all said and done, behind the so-called doctor figure, we are also human beings at the end of the day. We cannot, in fact, these things actually has a long-lasting effect on us. When over a period of time, we kind of let it out somewhere else. But it does have an emotional bearing. Again, breaking somebody to be on insulin 4 shots, especially treating somebody below 10 years is a big challenge. In fact, psychologically, it takes big toll, and I in fact, I'll be more happy if somebody I kind of push it off, though I don't want, in the sense, not that I can't do justice. It's sometimes your emotional strength handling them, because it's not easy. But again, giving a proper diagnosis and giving that family support is very important. The thing is, you need to keep things simple. That's very important. First thing is, obviously, there's a lot of anxiety. There is a phase of depression, and whatever you tell them, the first 4 weeks they would go full on. But what I would say is, then it kind of plateaus. But I think you should not have that ups and downs there. You need to all I would say is suggest them is to continue what they're doing, but incorporate those subtle changes. In fact, it's a blessing in disguise that if others also follow the similar thing,
Right.
even whether they are pre-diabetic or normoglycemic or whatever, they will not progress. So that's the other way to look at it. Is those who are on insulin. That's the other bigger challenge. Now, I go to a wedding, I should take insulin. What will people say? You're already reached insulin. Insulin, once on insulin, lifelong insulin is not the criteria. So there are a lot of people, I would say easily a very good number. I aggressively use insulin at diagnosis when HbA1c is about 10 or 11, only for 3 to 4 weeks.
Oh.
A short course of insulin, whether it's a basal insulin or a premixed insulin, that's more of the technicalities there. A lot of people use a very short course, and they would be off insulin after 4 weeks. And generally, when you do well, they would be put on medications. In fact, there are a couple of people who have even had remission and kind of been on minimal medications. But initially, when you treat aggressively with insulin at diagnosis, especially in people with very high HbA1c, 11, 12%, it actually benefits to recover their beta cells.
Oh.
That is something which is well known in the medical field. But the problem in inertia is I'm diagnosed, and first only the doctor is talking about insulin.
Insulin, right.
But that's not the fact. So if you give the right treatment at right time, kind of you get a very good result. And probably I have now 5 years, 6 years follow-up, where being on insulin initially till date, the average has been below 6.5 with very minimal medications, probably once daily or twice daily. And the same pattern was treated in a conventional way with 12% with medication. He did respond, but probably has not got the kind of stability what the person who received in insulin at diagnosis. And this has been published in a lot of case reports also. So it's not something new. But the general stigma is once on insulin, lifelong insulin. I'm not talking about that subset of people where you have 15, 18 years of diabetes, you've been on 3 pills, 4 pills, still your average is not under control. There I introduce insulin. Very unlikely that you will be off if you have kind of tried all the pills and you're not getting under control. I'm talking about that small subset where you give for a short course and you stop it.
Okay.
But again, as I said, the right treatment at right time.
Yeah, that's very interesting. Okay. So, is it true? Again, I have a lot of questions like this. Is it true? Because I've been hearing that when it comes to sugar and diabetes, right? So, is it true, like if someone is going to the gym and working out and you sweat out a lot, is there a dip in the blood sugar levels? And is that risky?
So, it's a big challenge there. And today with the technology there, we have a lot of continuous glucose monitoring devices, CGM devices, very small patch, which will monitor your blood glucose levels almost. You'll get around 100 to 100 readings in a day. You can also parallelly monitor yourself through your mobile phone. You can have an NFC mobile. You can also track it. So there are 2 spectrums again there. You work out a lot. You will have a dip, and then again the blood glucose levels can go up. Your counter-regulatory hormone starts. Especially this is something which we see in type 1.
Okay.
There this imbalance is, the fluctuations is more. So in fact, people who work out more, kind of the glucose level goes up. If there is a strenuous exercise. So in fact, before meal you need to monitor, post meal you have to monitor. Very difficult to predict. Is it because of the exercise, or is it because you have a hypo? Or in fact, your glucose, you'll say, before gym my levels were 170, 180. Post this strenuous thing, it's gone up to 230, 240. I have not eaten anything. This happens in type 1.
Oh, okay.
Type 1, managing type 1 is a big challenge. In type 2, it can dip. Probably you're doing a medium intensity exercise. But again, you do a strenuous form of exercise, then it can go high. So again, the sweating is not a parameter to say that it has gone high or low. You need to check. Probably a CGM device will tell us whether it's really going high or going low. Because again, each person, it differs. And again, a lot of people think that I'm going to gym, let me eat something and do.
That is...
Nothing is going. In fact, levels would be on the highest side. And again, as I said, the kind of calories they would be burning in gym would be much lesser than what they would have eaten.
So when you say that, right, they are monitoring also, but when there is a dip in sugar levels, it will lead to multiple other complications also, isn't it?
So in some subset of people, body again compensates. So you have 70, 60, you may not be symptomatic. In some people, you would feel tired and there will be an increase in your counter-regulatory hormones and the glucose level goes up. Generally, you would see some giddiness, you'll have this hunger cravings. In a younger person, you would probably not see the classical symptoms of low sugar.
Okay.
Probably in elderly, you would kind of see that they're not able to do that. More irritability,
Right.
all those typical symptoms can be there.
All right.
What is it with diabetes and footwear?
Okay. Very important question, actually. In fact, somebody walks in, first I see in my people is the foot. Foot gives a lot of information if you properly examine. So, neuropathy is a very important complication in uncontrolled diabetes. The other issue with the foot is the blood flow to your feet. So, what you call as a peripheral vascular disease, PVD, what you told as a macrovascular complication. Because of the decreased sensation, which happens eventually, in spite of your good control, the duration itself is a risk factor. Somebody with 20 years, 25 years, they would have some mild sensory neuropathy. Over a period of time, they can have, though they may have, some may have numbness, some tingling sensation. There are people with loss of sensation also.
Okay.
So probably they walk, they would not have the right gait. They would be putting more pressure than what is expected. Again, the other conventional national footwear is the Hawaii chappals.
Right.
So, or any chappal with a grip. So already they would be having some amount of clawing. The feet generally becomes, if you observe their feet, they would, because of loss of these intrinsic muscles, they would have a little clawing. The foot shape itself, there will be mild deformity. So they try to hold.
Okay.
When they hold like this, their forefoot becomes more prominent.
Okay.
So they develop cons or callus we say, callosity and cons. So generally, eventually some people go pick up, put con bandages. But the point is, why is the con developing? Is because there's abnormal pressure in your foot. Why is that happening? Because you have neuropathy. And now in a Hawaii chappal, what do you tend to do? You try to hold your the fingers like this, and when you do it, this becomes more prominent.
Okay.
In fact, while walking, the gait won't be proper. In fact, your footwear may slip. That is one thing. When there is loss of sensation, the first thing we say is avoid barefoot walking, both inside and outside the house. So inside house also, you should have a separate pair of footwear. Outside also, you should have. And an ideal footwear should be a sandal would be better, because you don't. I'm talking about somebody with diabetes with neuropathy. I'm not talking in general, because here sandal you try to put it completely. You don't try to hold it. You have something. You have the sole is very important. You either use an microcellular rubber MCR or an MCP, which is neither too soft, which is neither too hard. If the material is too soft, over a period of time there will be a depression in that area. So again, only on that area would develop a callus.
Okay.
So only these two materials tend to have. Again, a footwear should be customized. It is not like that everybody uses this black footwear. Ideally, you should do a foot pressure study. You need to see your pressure points.
Is that called podiatry?
Yeah, there is, yes. Pressure studies, you see the overall your gait, you will do the gait analysis, and then you design a footwear. Obviously, the cost becomes a factor. But in general, if you can kind of change at least the basic MCP or MCR sandals with heel counter. Heel is something which covers your back. Because, or you can have something called as a rocker modification.
Okay.
What is a rocker modification? Your footwear will have a 20 to 30 degree elevation. So your forefoot pressure is kind of, when you walk, the forefoot is a very simple technique. It's not something complex. Even most of our footwears have a mild rocker. Other thing is the toe box. What is toe box? The front part of your footwear. Ideally, it should be wide. What do? We tend to have a narrow toe box.
Right.
So the fashion comes in. Your footwear your feet is kind of cramped up. So over a period of time, when you keep wearing this wear, you will definitely develop a deformity.
Okay.
And again, what will happen when the toe box is too narrow? When you have this interlocking of your toes, there is an increased chance of fungal infection. Yeah,
Oh, because it's always closed.
Closed, more marginal. Generally, people without diabetes have fungal infection there. In some people, their foot itself, you would see that there will be a overriding of toes on each other.
Right.
So, and again, the nail is very important. Some of these important things is, one is, when you have neuropathy, avoid barefoot walking. This is the place you would go barefoot inside your house. terrace, temple. These are three common things. So we would say, how can you walk in a temple without? That's the thing which you need to strike a balance. Now, if you have a high risk foot, where you have loss of sensation, you already had developed foot ulcers, the best suggestion would be, we're not saying not to visit temple. You need to visit, preferably plan in the evenings. Preferably do not in the hot summer when at 1 o'clock you want to have a darshan, then it becomes difficult. I know at some places you have to go. Luckily, you do get temple socks. And some people kind of follow. I mean, they know that when you have these issues, they kind of be a little relaxed. You use this specifically for these pilgrimage you can use. But again, post that you need to examine your feet and do those basic foot care. And in other set of people, you can have a footwear within the house, especially if you feel that there is complete loss of sensation. Barefoot walking can at least lead to recurrent foot ulcers. So somebody would do your surgery or amputations or whatever. The other bigger challenge is you can again develop an ulcer in the same area if you don't offload well. When I say offload, it means an ideal footwear. And again, customizing each one based on the foot condition is very important. You cannot generalize saying that use anterior rocker for everyone, use only MCP sandals for everyone. You cannot customize it. And other big challenge for the foot issue is the smoking. So when I say peripheral vascular disease, smoking definitely happens. Just like heart attack, you have something called as foot attack. The blood flow for your leg comes down, and ultimately the ulcers are non-healing because the blood flow is not there. So everything has to go hand in hand.
So, does diabetes cause mortality?
Definitely, people with uncontrolled diabetes will have an increased risk of mortality compared to the normal population. And I gave you the example of COVID there. Not that everybody who had people with diabetes who had COVID had a very fatal outcome. People with uncontrolled diabetes had fatal outcomes. So that applies across. It's not only for. So it's like adding, if somebody's diabetes is uncontrolled, you have a bad infection, a pneumonia, or any other secondary infection, your chances of leading to complication is much higher in somebody with uncontrolled diabetes compared to a normal population. Just because you have diabetes doesn't, you don't have to worry that, oh, my lifespan is going to be. As I mentioned, we recently published also, and there are people who are living up to 90, more than 90. Healthy. And it's all about, in fact, people with diabetes are generally more disciplined compared to the one without.
You've had all your patients to be very disciplined, is it okay?
No, and with, as you said, with somebody in the family, if you have, I think others also kind of follow the, be it the diet or be it that, kind of that discipline comes by default.
Okay. So thank you so much, Dr. Praveen. It was definitely a bundle of information that I've got today about diabetes and sugar, and things that were definitely a myth, right? Do not eat mangoes. Mangoes is a no-no. It is definitely a breaker.
In fact, a couple of years we had somebody telling you eat mangoes and will cure diabetes.
Oh, wow.
So that was during the pandemic we had.
Okay.
But people with diabetes can definitely have mangoes. But as I mentioned, in moderation, ideally before the mango season, aim to get your A1C below.
I think you're going to have a line of people coming in and telling, I want to have mangoes. But I have diabetes.
As in every show, the TNC applies. So like in every ad, you get a
right.
terms and conditions.
True, absolutely. It was definitely an insightful conversation with you. Thank you so much for your time. I hope our audience also would definitely gain a lot of knowledge and enjoy the conversation that we had here.
Thank you. It was a real pleasure, more of a candid discussion with you, and I'm looking forward for much more meetings in future. Thank you.
Thank you so much.